NP with structural heart cardiology, and I do the TAVRs and Mitral Clips. And I just wanted to come talk with you a little bit about the TAVRs and the Mitral Clip Postop, because you guys are going to probably be seeing them more often. But I think just due to bed availability up in CCU. But these are the two valves that we have on the market. This one is called the Medtronic, okay, and this is the Edwards. So those are the two companies that make these two valves. They're both obviously different. This one is self-expanding, so the material that it has is called nitinol, and it's really crimped down, and then when it reaches the blood, it expands. This one expands with a balloon. So when they put this in, they put a balloon inside and expand it. So I'll just pass these around. Those are the two valves. And this is basically the size of the catheter that they use to put it in, which would explain why we're so paranoid of the groins, because that's how we do this percutaneously through the groins. And we'll talk about TAVR first, since we do a little bit more of those. But TAVRs are aortic valve replacements percutaneously. And just femoral is not the only way to do them. You could do them subclavian, you could do them direct aortic, you could do them carotid. But for us, the most common is the transfemoral, and we also do a direct aortic. But I think the direct aortics are more like a surgical and would go to the surgical ICU. So when we talk about a transfemoral TAVR, we use both groins. And the big sheath, which is usually a 14 or 16 French sheath, goes in it's the major access. So one of the groins will have the major sheath in. The other groin usually has like a 6 French that they use for a pacing wire and an art line, but that's usually out by the time they come to the PACU. If anything, the major access one is out. If they leave one in, it's usually the other groin. The major things that you look for when you are taking care of these guys are bleeds, right? Femoral bleeds. 30% of patients usually have some kind of bleeding afterward from TAVR, from the major access. Pressure is usually what you start out with, and if you're noticing that the pressure isn't holding, you're holding pressure for 10-15 minutes and it's not going away, then you just got to let us know and we'll come down and take a look at it. And that's Dr. Adianzar. Do you guys know who she is? Have you met her? She's the interventional cardiologist. She's usually the one running the show after, as well as Dr. Lee, who's the CT surgeon. So if you can't get a hold of one of them or me, usually you get a hold of one of us, or even a cardiology fellow would come down. But when they're hanging out in your PACU, the 3 biggest complications after TAVR are bleeding in the groin, are heart block, and stroke. So those are the biggest 3. Those are the things that we're looking for right away. You'll know heart block, right, because you'll be able to see the EKG monitor. They're all monitored. Some of the patients already have pacers and ICDs prior to going in. And the biggest thing you'll see is a right or left bundle branch block. That's what you'll notice. If you see that and it's new, you gotta call somebody just to let them know, okay? Because that's a huge complication. Some patients have to go for a pacer. If that doesn't recover, sometimes if we think that they are coming out with a block, we'll leave their pacer in, their temporary pacer, which will be an IJ pacer. Have you guys ever worked with any IJ pacers? Yes? So you know how to, no?
No. Yeah, probably I'm the only one.
Okay. Well, that's because of the unit, right? Working in the unit. Okay. Well,
And Brooke.
They'll have a temporary pacing wire coming out of their IJ that will be hooked up to a device. If that's the case, somebody will be down there to go over all of that with you, so it's not anything. Hi.
Yeah, good morning.
You want a donut?
Good, thank you. Thank you.
We can get the education out about the Medtronic pacer.
Oh, okay. About the temporary pacer that they use or we use. We've only had one patient or two patients out of, we've done 56 TAVRs that have had the temporary pacer. And they ended up actually not needing a pacemaker going home, so it worked out well. These guys are all usually 24-hour stays. They come in the morning of the procedure, and they go home the following day, usually by noon. Most everybody does. If there is any indication on their EKGs, like they have a block or the rhythm is slow, we will keep them for another day. But otherwise, they're usually good to go home. And the important thing to remember for that is that it's kind of like a calf. You know, they haven't had open heart surgery. They don't have any incisions. They're all good to go home. But they're already in CCU by that time, I'm sure. You won't be discharging anybody from the PACU. I did bring the valves for you guys. One is the little one is an Edwards, and the bigger one is a Medtronic. One is made from cow, which is the bigger one. The other, I'm sorry, is pig. The one is made from pig, the other is made from cow pericardium. So you don't need anticoagulation for these valves as far as Coumadin. They go home on Plavix and aspirin for 6 months. It's not quite the same as having a mechanical heart valve. But as I was telling them, the 3 major complications after TAVR are bleeding at the groin or wherever we go in, and stroke and heart block. Those are the 3 biggest. So that's what you guys will be paying attention to when they come out. We also do ACTs usually. And I don't know, I was told you guys did not have an ACT machine. So how do we do that?
They don't get them till they get upstairs.
So I think, yeah, we're gonna have to figure that one out, because depending on how long they'll be down here, there's another sheath. So you always use 2 groins, right? The one sheath will be able to come out when that ACT is less than 200. But she said that we could run it through anesthesia. Doesn't anesthesia have the ACT machine? Okay. Do you guys pull lines at all?
Mm-mm.
Nothing. Okay. So it would have to be done by like a fellow or something. Okay. But anyway, when there's the groin line is in, we would check an ACT every 1 to 2 hours. When that ACT is less than 200, we would go ahead and pull the sheath out. Hopefully they're not down here. You know, I don't know how long they normally stay, depending on the bed availability. What do you have question? Have you taken care of them?
Can you talk about the importance of lying flat?
I feel like if you could get down to like, at least is how my brain works logistics wise, like the nitty gritty of like
What you have to do?
Yeah, Q15 neurovascular checks times how many, the lay flat, like when we had ours first one roll out, we had no idea. So if she needed to pee, we're like, oh, we'll put you on a bedpan, and someone happened to mention like,
what I
like
was told.
They are
But
log
then-
roll.
But then later I found out you do not turn them like during
That's not
the
true.
term. Okay.
Yeah, so there's been a lot of, I don't know why that is, but when they come out, they need to lay flat for 6 hours. There's no doubt about it. And we usually have been putting those long leg immobilizers on both legs, depending. Usually the one with the bigger sheath, we will definitely put it, it's like the knee immobilizer, but it's the whole entire leg. I don't know if that helps or not. I think Dr. Adianza thinks it helps keep the patient know that they have to keep their legs straight. Sometimes we'll use both legs. We'll put it on both. So if they come out and we need to get that, we have to get that. Is that easy to get? A leg
it would
immobilizer?
have to be done through the OR. Like basically once they come in to pack you, when it comes to like supplies, it's all in the back.
So, but somebody could get that, or
I don't know how that works in terms of a charging aspect. Like they end up charging the patient for any kind of equipment like that they would pull. And typically, like if you notify the OR nurse, they would be able to get that and have it on the patient before they get to pack you.
yeah, okay. Let me work on that. I think there's a lot of breakup of where they're just trying to get the patient off the table because they want to start the next case, right? So any kind of delay as far as putting a mobilizer on,
I mean, if they make it like a part of
like a pack.
like a checklist almost, so like just to have it, because I mean, I'm assuming that pressure needs to be held at some
Even if they
point.
just throw it on the bed.
Okay, so I just have to get them to include it.
Mhm.
Okay. Okay, so yeah, they have to lay still 6 hours flat, and that's 6 hours from when the last sheath is pulled. Most likely they're coming to your unit with a sheath still in. Okay, so their 6 hours is a long time. They'll probably be upstairs and before their 6 hours is up, but they can log roll these. I don't understand the PureWick suction situation. Those things
It's
are
wonderful.
frightening. I mean, so they use that all the time up in CCU for the men. They use a condom catheter. We do not want Foley's in them if we can help it. The Foley's just prolongs their in-house. Most men's prostates are huge, and maybe they don't know it. So then we stick a catheter in there, and they're never coming out. So if it's at all possible, now if it's extenuating circumstances, that's a whole different different thing. But usually log roll for bedpan, they can roll. I guess I was upstairs in the CCU and they were telling me that do we let them sit in their own stool? And God no. I mean we have to be realistic, right? Just keep them just like a trauma, right? Just keep them all
Keep their run
level
straight.
and turned. Yeah, it's totally fine. You shouldn't have to do that often. So what else? Labs usually are right out when they come out. The neuro checks are Q4 or Q15, usually for 4 hours.
And then it's Q30 times 4 and Q1 times 4. And that is in the access post-cath.
Yes. Do you have access to the
Policy.
orders? Okay. So I put the orders in before they get off the table. So usually the immediate stuff is labs, and then that's it. You don't have to do anything else unless you're seeing something that's out of whack or something like that. We don't do chest X-ray. You don't need a 12 lead. You don't need any of that.
And these
Okay.
patients get discharged from CCU, or
Yes.
do they go to the, okay.
We discharge
Because then
them
I
from
just didn't know,
CCU.
like, it's obviously like an outlier, it's not the norm. But if we end up having this patient, I've had them to the point that by the time they've gotten to CCU, they're on Q4. So I don't know.
Q4, what's that mean? Vitals?
Like Q4 the vitals, Q4 the neurovascular checks. Like I've kept him. He did not have a sheath. He's done his 6 hours down here. So by the time I've gotten up to CCU, they're now in the phase of where they're going to be sitting him up.
Mm-hmm.
They're-
Getting out of. I didn't think that CCU ever did Q4-hour vitals though.
But I just meant like in terms of they're out of that acute 6 hour
Sure.
phase. So then from the I'm just thinking from the logistics standpoint of if it's potential to go to a 6 North bed versus a CCU bed.
CCU.
Okay.
Right now, CCU. We haven't gotten to the point where we can just send them to 6 North. We hopefully will get there, but they don't have telemetry. Or they do, but it's down the street, right? They're monitored. So I don't think we're quite ready for that yet. So right now they just go to CCU, regardless of how long they hang out with you, right?
Okay.
Yeah.
That's what I said.
If there's something weird like that, like they've been with you for, I don't know, 12 hours or something, then I'll figure it out. Maybe we would do something different, but I can't imagine them just going to 6 North. Although it seems odd, right, to go to a unit and get discharged from there, but it's worked out very well so far, so yeah. Okay. What other questions do you have on taking care of them? Usually the order situation, they will start Plavix that night. Plavix is usually the one thing we do start. Sometimes the rest of their medications, like beta blockers, are just going to be dependent on what's going on with their heart rate and what's going on with their pressure and so forth. I'm sorry.
From a pre-op standpoint, what labs and are you doing any EKG?
Are you in pre-op?
We are. We testing.
Yeah. So you do not have to mark the site.
Okay. Y'all are good.
If I get called on that, I'm gonna stroke. Can you
They'll-
take that out of
They'll
there?
still make mark the armband.
I get called all the time. I'm like, what site would you like
They'll
me
still
to mark?
They'll mark the armband if there isn't a site.
I don't even mark the armband.
Well, whoever's in pre-op may make you do that in holding.
So there's no
letting you
site
know.
to mark because you go through both groins.
But even like for midline cases, they're still making them, like if it's
What's a midline case?
like a bladder, if you're having bladder surgery, there's only one bladder.
Because you're
they're
having
still
an
marking-
incision. We're not doing any incisions here.
Well, it
Yeah.
should be a little incision.
There
I used
isn't.
to work in a cath lab, they make a slit and then they access. But,
You don't
I mean, it's
mark
not
this
in-
site for caths, do you?
Or like GYN procedures,
No,
they're still
they
making
don't.
them do the arm and.
You don't mark the site for caths, so there's no need. I think everybody knows that up in pre-op because it was really starting to annoy me about marking the sites. But I think like, what site would you like me to mark? Every artery that they have? Because it just, usually we go groins. If we don't do groin, then it's an alternative access. It's either subclavian, which is a whole different ballgame, right? Because that is an incision, or direct aortic, which is an incision. But if we're doing transfemoral, you don't have anything. Their labs, they get CBC, BMP, coags, and I do an NT-Pro BMP, and they all get type and crossed so that one unit is available, so they'll all have blood available. They get an EKG. What else do they get in pre-op?
Are you clipping or you want them clipped?
Oh, they have to be clipped. These are
Okay, so I-
so similar to,
A heart.
because,
They're
yeah,
usually
because
heart.
if something happens,
and you
we
can access.
go to open heart.
So you went chest and.
Yes.
Okay,
And they've been doing that.
yeah,
Yeah. But yes, both going. So you treat it similar. I think on the orders it's as similar as an open heart.
okay.
What else did you have?
Yeah, and I'm gonna say that real quick, because we do appreciate you, because you were very thorough about that, about putting your orders in, and
Yeah, I
it
tried.
makes it easy on us, you know, and instead of trying to, instead of waiting and then delaying the patient, you know.
Oh yeah.
So,
There's
we
such a push, right, to get in the OR, get the first case started, and you know now they want us to do 3 a day. So, and I usually put the orders in way ahead of time, and if they're not in there, you just have to text me or through the messenger or whatever. And I will, and plus consent is another thing that drives me to drink. How it doesn't get in that chart, like I physically now walk it to PAT to get it in there. So, and I always will carry a spare with me, just in case. So I'm always big about consent too. But you know, they should be ready to go, right? There's no reason for delay. Unless the patient shows up late, which obviously happens. Anything else in pre-op? No.
No,
Yep.
I just came to kind of understand it more, because we get questions pretty often.
You know, they get an antibiotic, they get an antibiotic post, so depending on what they got pre, cefazolin or usually Vanco, it'll be the same post as well. I think that they're starting them in pre, or maybe they start them down here. Okay.
Yeah.
That's it for that. What else? What other questions do you guys have?
Do you see more like retroperitoneal bleeding? Would it
No.
working with larger?
No,
You guys
actually,
have-
it's like at the site. It's
Okay.
not gotten to
Sure.
that point where we have had a retroperitoneal. Usually it's just the site, and because, yes, the site is big, right,
Yeah, I'm
compared to what
thinking
you're
going
used
in that
to.
vessel, the likelihood of you hitting the posterior side is probably great.
Yeah, and well, 30% have bleeds, but don't go into the retroperitoneal
Oh.
part, but just at either femoral dissection, even some radials, because we do use radial arterial lines, so sometimes we've had that as well. She will use femstops. I don't know if you guys are familiar with femstops. Okay. If we're having a hard time and there's you're not getting it to stop, she also uses epi, and I can do that where I inject it just at the site, because it's usually like a skin tract. The reason is it's not that the artery is bleeding, it's that the subcutaneous tissue around. So sometimes we will use epi as well. She'll inject it. She calls it sub-Q epi. You guys have that, right? Yeah. So what other questions do you have about these guys? Hopefully they're not scary, right?
So can you explain, because I had one come out not long ago, they said it was an open TAVR, but not an open heart, but an open TAVR. So what's the difference? What's an open TAVR?
An open heart.
But, so it wasn't an open heart. It didn't
They
get
didn't have a
SSU.
sternotomy?
No, they went in subclavian, but they called it an open TAVR. Were they just
Yeah, there's no
misinformed?
such thing really as an
Okay.
open TAVR. That's just an alternative access.
Okay.
We're actually doing one next Tuesday, which is direct aortic, which will be an alternative access.
Okay, so
maybe
it's not
they meant
called an open
alternative. It's not
TAVR.
called an open
Okay.
TAVR. An open TAVR is an open heart.
That's what I
If
thought
you have
too.
to
So I was
open
like,
them. The two things we do are full crash or fem bypass. So those are the two fixes for if somebody has to be opened emergently. It's either a full sternotomy or doing fem bypass. Okay.
okay.
Yeah, there's no open.
Because they're like, no, well, this is planned. It wasn't an open heart. It's an
Yeah,
open
that's
TAVR.
alternative
So it
access.
was
So,
just-
yeah,
okay.
that's what it's alternative access. So subclavian.
And it was
Yeah, and it's
subclavian.
like a small incision.
It was.
Yeah.
Okay.
So, what else do you guys have? Any questions? Mitral clips are the same, similarly the same. The difference with mitral clips is they're venous access, not arterial. So the sheath that they use is a little bit bigger though, it's like a 20, but it's usually right femoral vein is the access. You don't have bilateral accesses like you do TAVR, so it's just the right femoral vein. They get intubated because you have to go across the septum. So whenever we go across the septum on a case, these patients are all intubated. So they're intubated, they get extubated on the table usually. Sometimes that's not the case. And they're kind of treated similarly as far as what you do post-op, labs, same thing. Their site is out, so you're just checking for bleeding. The mitral clips will have a suture. It's called a figure 8 suture in their right groin. Hopefully that detains any bleeding, but we have had bleeding around it, so it's just a matter of holding pressure again. So those are the two cases, a mitral clip, and that's for severe mitral regurg, and a TAVR is for aortic stenosis or aortic regurg. Okay. And I'm available whenever, so if something's not right or you have questions about anything, just, I don't know if you have my cell. You have my cell, right?
Mm-hmm.
You could text me or message me or whatever you can do about that.
Connect Messenger. I mean, she's very responsive.
Yeah, I'll call you. If I'm doing something, I'll tell you, but usually you can always, and I'll be over there anyway, hanging out when they get off the table, just to make sure everything's good, and if there's anything you guys need or something's not right or the orders are jacked up or whatever, just let me know.
So you
Take
talked
care of
about
it.
a little bit about heart rate and monitoring the rhythm for heart block. What about hypertension?
Hypo
Hypo or hyper?
Hypo,
How
usually
aggressive?
anesthesia is usually less than 90. I think systolic, same as anything else you probably are used to. I would consider that to be hypotensive. They're probably getting fluid when they come over, usually anesthesia, but you've got to be careful with them because a lot of them have heart failure, so we don't want to push them in the wrong direction, but you've got to have a good pressure. Some of them are on drips still. Like I know that anesthesia sometimes will start neo or something like, or epi or something like that in the case, and I'm not sure if they're coming out on that. I think it's a mystery on what anesthesia is able to get off. Usually hypertension, 150s, 160s, similar to probably what your normals are. And a lot of that is just, we haven't started their antihypertensives yet, like their Preop meds. They're all on beta blockers, right? Coreg and hydralazine and everything. So it's just a matter of getting those restarted. They'll all have art lines. All of them will have art lines, so they'll come out with an art line. Okay. What else? Heart rate wise, just making sure you notice if they have a block or not. That's the biggest complication, is heart block requiring a pacemaker. It's usually less than 10%, but it's still there. And a lot of these patients have pacer ICDs. The reps all know. I usually take care of that myself, letting the reps know. So if you have a question about anything with the pacer or ICDs, let me know. What else? Questions? No? No?
We're good.
All right.
Thank you.
You're welcome.
Jennifer, I was just gonna ask, did you demonstrate how you do this? Because we missed that, like with this device.
Okay, this is the catheter. I just wanted to show the size of the catheter that they use because it's like 14 French sheath. They used to use 20s. They use 20s for the mitral clips, but now they're getting down to the 14, so they're not as big. But this is the device that we use for the Medtronic valve. So the Medtronic is the big one that crimps down and actually goes in here.
Wow.
So this is how it gets delivered. So then Dr. Adianzar and Dr. Lee manipulate this thing in order to get the valve released. Both docs are in there at the same time, okay? Dr. Adianzar and Dr. Lee. So the surgeon, Dr. Adianzar, is the interventional cardiologist. Okay. But yeah, this is it. And I don't really know what all these buttons are, but I thought it looked fun, right? Just to see how big it is. You know, this is why people have groin bleeds. And you know, they all get Plavix. Some of them are coming in on anticoagulation that you can't stop, and not everybody gets reversed. So protamine is the big thing. You should get that in a report if they've gotten reversed or not, and know that, because that's obviously important for you guys. But
That's another question. The anticoagulants, so it just kind of case by case what they should not be taking, like Plavix and baby aspirin and.
so I always put a note in on every patient that says what I'm stopping and what they need to continue.
Okay.
If it's Plavix for a fresh stent, they have to continue. No, but I don't really care about aspirin. They can be on aspirin, not a problem. Coumadin, they're either I'm stopping it or bridging. Eliquis is always 48 hours, you can't bridge. So I will always have a note in the chart that says like pre-op instructions, I think is what I name it, on which, and not to say that the patients listen to that, right? 'Cause they'll come in and-
That's all we verify.
Right. They'll be like, oh, I forgot to stop that. You know, just let me know if you have one that didn't stop taking Coumadin. Because that would be a big deal, right? Their case may not go. But usually Plavix isn't an issue, or Xarelto or Eliquis usually for one day.
Okay.
So, what else? I don't know. We have 2 cases tomorrow, 2 TAVRs. We usually do them Tuesdays and Mondays if I can. I just wasn't able to get any OR time, hybrid time this month for Mondays. So we'll do 2 cases Tuesday. Eventually they're going to do 3. I'm dreading that right now, but we'll see how that goes. We have to get faster. So anyway, just the whole process has to get faster. You know, they're down there now. We're starting at 7, right, on Tuesdays. Last week we were out at 10:30. Started the second one early, which is why they're getting antsy to do 3. And we have the patients, I have them. So I would like to do 3 as well, but not be here till, 10 o'clock at night. So that seems to be the goal. But is there anything else you guys have? Or my last name's Davis. I don't know how I'm in the messenger,
Jennifer Davis.
but there's a couple of us, I think. Just look for NP, maybe. That will. There's a couple.
And cardiology.
Oh yeah, maybe
I'm
just
sure if
cardiology.
you-
But that's it.
Thank you.
Thank you.
Thank you, guys.